Hello, I'm Dr. Michael Graham, and we are here tonight, hopefully, all together. Hopefully this is working, talking about plantar fasciitis and myths and treatment updates. And I know that this is a very, very common condition. I mean, there's several million cases of this that happen every year, and it can be a very painful, long process. And so what we want to do is talk about certain myths, the biomechanics, pathomechanics, and various treatments for this condition. So let's get started. So the plantar fascia is this long band of tissue, which most of us are very familiar with, that begins from the heel and extends to various parts of the feet. Throughout time, they've shown with these anatomic studies, and there's some misconceptions out there, that there are really three bands of tissue. We have the medial band, which some of us call the central band, is actually starting from the medial heel, and it attaches to the flexor retinaculum. The lateral band goes pretty much on the lateral column of the foot. And then we have the central band that primarily functions on the medial column of the foot bones, but it also has some extensions into the fourth metatarsal as well. Now, the function of the plantar fascia is pretty straightforward. I'm focusing on the central band because that's the one that becomes pretty much symptomatic for most patients. So it stabilizes the medial column of foot bones. And we have the lateral column and the medial column. The medial column has much more motion that occurs in it. The lateral column is a very stable column, and we really don't have any motion that's supposed to occur there. So the other thing with the plantar fascia is it's going to help to propel the foot forward during the gait cycle, and it stores energy through the windlass function. And I'm not going to get too much into that right now, but there should be just a very, very slight tugging on the plantar fascia. We don't like to say that there's any elasticity because these are not elastic fibers. They're very different from a ligament or a tendon. We have to think about the strain that occurs onto the plantar fascia. And what really controls that strain is the tension on the fascia is the talotarsal joint range of motion. When the talotarsal joint is maximally supinated, this is when there's going to be the least amount of strain on the fascia. Now, if the foot is in the air and there's no weight applied to the foot, there will be no strain whatsoever. Then the most amount or more strain is going to occur on the fascia during talotarsal joint pronation. So supination is less, pronation is more. Pretty simple. We all go back to this walking cycle of a stable talotarsal joint, and we see that the talotarsal joint should only have a very slight amount of pronation during the early stage of the mid-stance. And so that means that we should have just a very slight amount of the strain acting on the plantar fascia at that point. But then as time goes on and as the heel lifts off of the ground, right before toe off, that's when we're going to have the maximum strain that's going to occur onto the plantar fascia. And that's because of just the bend, the dorsiflexion of the toes is going to put an extra tug on the plantar fascia. So that's kind of the good, really down, dirty, and simple. You guys have had a million lectures on this, but I want to get into more of the pathology behind plantar fascial disease. That's the most important question that we want to ask ourselves. But of course, we need to understand the underlying pathologies if we're going to treat this disease process. So we need to know what is the leading cause of insertional plantar fascial disease, because if you don't know what's wrong, what's causing the problem, then how are we going to fix it? And what are the treatment options that we're going to offer our patients? Now, it seems pretty simple and a really silly question to ask, what is the cause of plantar fasciitis? I mean, even this little baby knows, it's like, duh, it's an inflammation of the plantar fascia. But is that really correct or not? Is that a myth or is it fiction? And it's very important because if we're trying to treat a patient with an inflammatory disorder and there's no inflammation to begin with, then it seems like we're kind of going down the wrong treatment path. Well, how are we going to find out if this is myth or is it a reality? And so several investigators have done the heavy lifting for us, and starting out here with one of my old professors, Harvey Lamont, who back in 2003 published histologic studies showing that there is not an inflammatory reaction occurring at patients who needed a plantar fascial release. So these are not patients who just had early forms of the plantar of heel pain. So what they discovered is that it was more of a fasciosis, that it's not inflammation, that there is a disorder occurring without signs of inflammation. And we have all these other studies here that have gone on to validate that initial study, showing that it is a overstretching of the medial band of the plantar fascia without the actual inflammatory response. Here's even some more. So take a screenshot of this. This webinar will be available on hypercaredoctors.com once I've completed this. So you're always welcome to go back and review this one or any of the previous ones that have already been published. So this is really not an itis, it's an osis. So if we're treating the plantar fasciitis, and I don't think that we'll ever be able to change that name to a plantar fasciosis, everybody's going to know it as the itis. But that's why a lot of the treatments historically given for plantar fasciitis just really don't work. They might, a lot of them will give temporary relief, and even some of the papers that have been published on those treatments are only very short term. None of them are long duration studies, so usually only a few months. So what's the difference between the fasciitis and the fasciosis? And it really boils down to one thing, is that we have a chronic overstretching of the plantar fascia, and this leads to a tissue degeneration at the weakest point of the plantar fascia, where it inserts into the medial and lateral calcaneal tubercles. Okay, so we have this fascial strain that's occurring. We need to find out, why is this tissue being overstretched? Because every tissue in our body has a normal amount of strain that it's that the tissue is able to withstand for somebody's life without it becoming diseased. So there has to be, we have to discover what is this excessive amount of strain. Now, I published this paper along with Dr. Kolodzy from Poland and Dr. Kimmel back in 2019, so this is just recently published. And what we found is we measured the x-rays of patients who had plantar fasciopathy or plantar fascial releases, and we found that almost 94% of these patients had a pathologic subtalar joint alignment. So basically, we showed that these patients exhibited excessive subtalar joint pronation, or more specifically, a partial dislocation of the talus on the calcaneus. So we had a subluxation occurring between at the subtalar joint. Now, there's been studies out there that show that this is not really a flat foot problem. And that makes perfect sense, because somebody that has like a rigid flat foot, they don't have that spring in their step. They don't have, so that means that the plantar fascia is not being overstrained when they're walking. What this is about is that hindfoot misalignment. This is a flexible deformity. So we go back and think about the forces that are going to act on the plantar fascia because of pathologic talotarsal joint displacement, RTTID. So here, look on the left, and we show that this is where the talus is aligned on the calcaneus. We have a nice open sinus tarsi. But then what happens when that talus partially dislocates anteriorly? That's going to cause an anteriorly deviated symaline, and instantly that's going to put a stretch on the medial, on the central band, acting on the medial column of foot bones. And that's why patients with this condition always complain of that inner heel pain, because that's where the tissue is being overstretched. Now, another paper, we're going to come back to this later on, but what I'm showing with this paper that was published in JFAS back in 2011 was that we found an increased strain because of the RTTID by 33% on the plantar fascia. So that's above and beyond what the normal strain should be. We're going to talk about the treatment of how we were able to get this research later on. So let's think about what happens with this partially dislocating talotarsal joint. So remember that we had the slight amount of pronation with a stable talotarsal joint, but now that we have instability, we have this an extended period of pronation. The foot bones are going to be in their unlocked position for a longer period of time, and that's going to place a lot of excessive strain on the plantar fascia all the way through the mid-stance portion of the gait cycle, and especially then at heel lift, because the talotarsal joint should resupinate to decrease the strain on that plantar fascia, but it's not able to when you have this extended period of pronation, the overpronation or hyperpronation. So again, we saw like this minimal strain, the normal amount of strain acting on the plantar fascia. And now we see that at mid-stance, there's a significant increase. And especially at heel lift, there's going to be a lot of strain that's going to act at the origin where the fascia inserts into the calcaneus. So that's the weakest point of this, of the fascial attachment. It's not distal. So I want to show you in a more clear fluoroscopy view here. This is at heel strike. We can see that the talus is properly aligned on the calcaneus. The navicular bone is elevated. The joint facets are in congruency, how they're supposed to be. We have an open sinus tarsi. Then we have the foot go into the mid-stance, and the talus has slid forward, and now we have obliteration of the sinus tarsi. And then we can see how the talus has pushed forward. It's forcing the navicular bone not only to fall downward, but it's pushing it distally too. So that's going to increase the strain on the plantar fascia. So right there, we've now discovered the underlying pathologic strain that is causing so many people to end up with plantar fasciosis. Okay, so this is extremely important. And you can all challenge this by taking the same x-rays of any of your patients who present with heel pain. Have them mimic heel strike, and then take another x-ray with their foot flat on the floor, and you'll see that the simuline, or that the talus is being pushed forward, and that's going to increase the strain. So this is a problem that happens with chronicity. It happens, the strain happens over and over again, thousands and thousands of times a day. And finally, the patient will reach the point where the tissues just can no longer handle that tissue strain. And that's when we now end up into this pathologic phase. We have partial ruptures of the band of the tissue, and it's trying to heal. So here we have a middle-aged person, and they're putting their foot from relaxed stance into neutral stance, and you can see the big toe extending beyond that yellow line. And just think about the strain that's being placed on the plantar fascia. Now, we're going to talk about equinus in a little bit, but you can see that by the patient just putting their foot through this range of motion, that we've eliminated any kind of excessive pull that can occur from a tight gastroc or tendo Achilles. So one of the questions that I always ask in my mini seminars that I give all around the world, and it's something that's already in the literature, but you already know this, is what decade of age, or how old are people usually when they present with heel pain? Is it in their teens, their 20s, their 30s? Well, usually the highest number of patients that come in complaining of heel pain are within their 40 years of age. And so by 40 years, the average person has taken over 72 million steps. So that's 72 million times that we have on average of a 33% excessive strain, not the normal, but excessive strain acting on that medial band of the plantar fascia. So I always like to use this illustration that if you just lightly tap your finger on the top of the table 72 million times, you're probably going to end up with tissue pathology. You're going to get a callus, and then that callus will eventually turn into an ulcer. So it's all because of this excessive tissue pathology. So just think about how that talus keeps sliding off. This is a problem that's occurring above the calcaneus, and the plantar fasciopathy, this plantar fasciosis, is a secondary disease that stems from the excessive subtalar joint range of motion. Yeah, you can see that that we've eliminated any of the excessive strain that could have been acting from a tight Achilles tendon. So this is the pathology cycle. We have the 33% excessive tissue strained over 72 million steps. That critical threshold is reached. Now, for a lot of people, the reason why not every single person with misaligned feet or this RTTID has heel pain is because the body will react. So we have both Wolff's and Davis's laws. And so why do we get those plantar calcaneal heel spurs? Well, the plantar fascia is pulling on the periosteum of the tubercle. So the periosteum senses, because of that strain, it's going to pull the bone out. It's going to stretch the periosteum. And so then the calcaneus grows that shelf of bone, which is trying to reduce that strain acting on the plantar fascia. That's why so many patients have heel spurs, but they've never had a day of heel pain in their life because that spur was able to compensate for the excessive strain. Then you have all of these other patients who don't have a heel spur, who have plantar fascial heel pain because their body has not adapted to that strain. So regardless of all of that, if their body has the spur or not, meanwhile, the patient continues to walk step after step. And so that's why we then end up with this repeated micro trauma within the plantar fascia. And here's all of these articles that talk about the histologic features of why that fascia becomes diseased. So you can see that there's so much literature out there that talks about this fasciosis, but we really don't have our effective treatment options for this. So anyway, so why does this fasciosis become symptomatic? Now, the plantar fascia itself was called the aponeurosis because apo means without and without nerves. So there's no nerves that are actually built into the plantar fascia. There are nerves that traverse through the fascia, and it's those nerves that are that become stimulated, and that's what causes the pain. So it's not the fascia itself, but it's the nerves that are innervating, like transferring through the fascia that become diseased. Now, we'll see that the fascia is a living tissue, just like skin, bone, ligaments. So it's going to have a zone where it's going to be diseased, and there's going to be degeneration and regeneration, just again, like most other tissues that become damaged. The only problem is that the body is unable, most of the time, to repair the damage so that it's strong enough to withstand that excessive force. So that's why the majority of patients continue on to have pain, or what they will do is they curb their weight-bearing activities, and so that they don't have that amount of pain, of strain acting on the tissue. So it's really a neuritis, and then it could be even a neuropathy that happens to the medial plantar nerve. So here's an illustration that shows the innervation of the proximal band of the plantar fascia, and it's this nerve that will become disease. It develops the neuritis, and then it can eventually, if we don't have an effective treatment, can actually turn into a neuropathy. Now, the post-static kinesia, so this is, we all know what this is when patients have pain upon standing. So we know that the plantar fascial disease is a weight-bearing disease, and when there's no weight on the patient's foot, the tissue is contracting as a defense mechanism to try to prevent the overstretching of the plantar fascia. But because the fascia is unable to compensate for the excessive strain, then the fascia will have to become overstretched again, and then the nerves are immediately damaged, and then they eventually just go numb. So that's why that pain goes away, is because of the numbness. And that's why then later on, as patients continue with this disease process, like initially the nerve pain will go away pretty quickly, but then months into the disease process, it'll take longer and longer for that pain to go away because there's just so much scar tissue built up around the nerves. So I do want to talk a bit about equinus, because there is the role of equinus with all of this, because there's a lot of speakers that are out there that are saying that equinus is the root cause of plantar fasciopathy. But I just want to present a different take on all of this. Now, the first thing that we have to understand is that about the stability of the talotarsal joint. So the number one portion that creates the stability between the talus and the calcaneus and navicular is the articular facets between all the talus and the calcaneus and navicular. There's a joint capsule around that articular facet, and then there's a vast network of ligaments. And so the subtalar joint, when it's normal, you can't really budge it. I mean, that's why people are out running and jogging as long as they can for very long distances, because they have a nice normal subtalar joint alignment. So to say that it's the talus or the tendo-Achilles is kind of pulling the heel out from under the talus, causing the excessive strain, that means that the tendon is going to have to then overcome all of the ligaments and joint capsules in order to create that from happening. Now, there's literature out there that absolutely shows that there's a connection between equinus and plantar fasciitis. Again, I'm going to say fasciosis. But so this is a study of 254 patients, and they found that a significant number, 57% of them, had a gastrocnemius contracture, 26% had both a gastroc and soleus, and 17% actually did not have any limitation whatsoever. So that shows us that this is not 100%, unlike the study that I quoted to you earlier that we had 94% of the patients had a subtalar joint misalignment. So there's an association, but the causative factor has not been proven. Now, here's something that is a very simple question to put this to the test or not. If you go in and perform a gastroc recession or a TAL, is there any evidence that shows that by doing that there's decreased strain on the plantar fascia? The answer is absolutely not. There is no evidence that has been published on that. The second factor then is even simpler, easier, is after a gastroc recession or a TAL is performed, does the talus realign itself on the calcaneus and also the navicular? The answer is the same as the before question, that they don't. There's no evidence of that. So equinus, let's talk about this a little bit. We have the two kinds, the congenital and acquired. So the congenital is when there's actually an anatomic shortening of the tendon, versus the acquired, which is more of a physiologic. Like if we were able to measure the Achilles tendon, it's normal. So this tells us that that there's, again, something else going on. And what that is has to go back to Mr. Golgi, who discovered this little sensor at the musculoskeletal junction or the musculotendinous junction. And these are a stretch fiber. And what happens here is that with the acquired equinus is that the tendon is being overstretched, which then causes the muscle tendon strain. And from there, we're going to get a neurologic reflex that is going to cause the muscle and tendon to self-contract. So this is creating that tight gastroc soleal tendon complex. So if you don't believe me, let's take a look here. And we see how this patient is going from neutral stance to relaxed stance. And so, here, this is a cadaver, but you can see when that foot is being hyperpronated, we have this strain gauge that's applied to the Achilles tendon. And you can see how that the gauge is elongating because there is a strain that's being placed on the tendon. So when we have this strain, like I was saying before, it's going to send that neurologic reflex up to the spine, which is then going to send a reflex to the muscle to contract to help stabilize the joint. Because that's the other factor with muscles. Besides helping to create motion, their second job is to provide joint stability. So if we have excessive if we have instability at the subtalar joint, then one of the most powerful muscles that are acting and helping to try to stabilize the subtalar joint is the Achilles and the gastrocnemius complex. So we have all these proprioceptors that are in there, and because the muscle's trying to act as a joint stabilizer, that's why it'll contract. So really it boils down to this excessive subtalar joint range of motion that creates the strain. So again, think about that this RTTID causes both of these tissue pathologies to occur. That's why they are associated or can be found in the same patient. So we have the fascial disease and then the contracture of the calf muscles in the Achilles tendon. So, and then this is what I was kind of talking about before. I mean, so the theory was that a tight Achilles is pulling the heel out, creating a lower than normal calcaneal inclination angle. That places the strain on the plantar fascia, and then the talus dislocates like that. But that's just not true. These patients that had that rear foot deformity, the talus was always out of alignment, and it's acquired. So little by little, the Achilles tendon becomes more and more contracted because of the chronicity of the disease, because the thousands of times a day that the patient is walking. So again, this lecture is about plantar fascial disease, not equinus, but we have to talk about that because there's that overlap between those patients. All right, let's get into treatment finally. So we know that we have this disease process and it's caused because of excessive hindfoot motion. So how are we going to treat this? And are we offering patients the right treatment? So are we treating the effects or are we treating the cause? Now there's so many different YouTube videos and different things that are on the market to help stretch that plantar fascia out. It seems like this is one of the number one treatments for treating heel pain is to stretch the fascia. But we just spent all of that time talking about the 33% excessive strain happening on the plantar fascia. So the plantar fascia is already being overstretched, and now we want to stretch it out even more. So that doesn't really make any sense. I mean, sure, when you first get out of bed in the morning and you want to roll your heel on the ball or any of these other contraptions, that's going to help to prevent or to help stretch out the opposite effect of the contraction because of the elongation throughout the day. But that's not a long-term solution. This is just a very short-term fix. Then we have ice the heel, and yes, that's great. That'll help to kind of calm down the nerves, and the Shockwave treatments, absolutely, they are helpful short term. The problem is that the studies just aren't there to show the efficacy of Shockwave treatment long term. The reason why we don't see that, and we probably never will, is because the Shockwaves are working to knock out the nerves. They don't repair the fascial tissues, and they do not address whatsoever the underlying etiology. So it's kind of like putting air in a tire that has a slow leak. It's going to help for a while, but eventually the air is going to leak out and you're going to end up with a flat tire again. So a lot of these patients will have to come back for multiple treatments, or then there's another situation that can happen to a lot of patients where their pain will eventually go away. But we're going to talk about that a little bit. Now, something else that almost everybody talks about is to get those great heel pain injections. And there's a lot of literature out there to show that this also does help for a little bit, but there's a lot of complications that can be associated with this. And so let's think about what we're actually doing here. If we treat them with a steroid, now we're treating an inflammation that's not even there. So we still have that fascial disease. So the steroid might work to help relax the nerve tissue, but really what's what's helpful is the anesthetic that's knocking out the nerve. That's why the patients will walk out with no pain in their heel. Now, what happens if you knock out the pain in somebody's heel? Well, they've been limping around for the past several weeks or months, and they have micro ruptures of their plantar fascia. So now that you've knocked out their pain, they almost have this exuberance of energy to go out and start walking and grocery shopping, doing all of these great things, except that they have a weakened, diseased plantar fascia. And that's why there have been papers published that show patients end up having a partial rupture of the plantar fascia because of the injection of the medication into their heel. And I don't really think that it's the steroid itself that causes the tissue to rupture. It's just because the patients feel better, they don't have that pain. And so with all of the excessive walking, and the strain when they're lift up their heel, that's what then can lead to the tissue rupture. One of the most effective forms of treatment is the taping and strapping, because this is very effective in reducing the strain to the plantar fascia. The only problem with this is that so many patients have allergic reactions to the adhesive in the tape, and the tape usually will only stay on for a couple of days. At that point, it has to get removed, and then the patient is now walking around again without the support on their foot, and so the plantar fascial strain is right back again, taking its damage on the nerve and leading to more tissue disease. So this is a short-term solution, not a long-term treatment. Now, foot orthotics is a multi-billion-dollar industry. My opinion is that if you wear shoes, you should have some kind of insert in your shoes. But when it comes to the use of an orthotic for treating plantar fascial disease, there's a huge question mark there. Now, all of you have had some patients that have had some relief. It's possible that you prescribed them a pair of orthotics, and your patient never came back after you gave them their orthotic, because you assumed that they were treated, that they were fine. But probably they went to somebody else because they didn't get the results that they were looking for. The reason why I can say that is because I'll ask you the question: have you ever had a patient come to you who's been to one of your colleagues and they didn't get the results that they wanted? And the answer is probably, yeah, you've gotten a few. So it really comes down to, does this orthotic stabilize the talus on the calcaneus to prevent that excessive strain acting on the plantar fascia? And the answer is no. There's absolutely no literature that shows a decreased strain on the plantar fascia with the use of heel supports. So some patients can have that temporary relief, but the problem also with the orthotics is that people are walking around without their shoes on all the time, and so we're back to that maximum strain on the plantar fascia. So the literature does not support the use of orthotics as a long-term solution for heel pain. This is a follow-up study of a gastroc recession. I just wanted to throw this in there because a lot of people are getting this surgery for their plantar fascial disease. And this one showed in the short term, almost 4 months out, that patients, and this is only 25 feet, that they had some improvement. But I wonder why they only followed up the patients for 3.7 months. I'm really even surprised that this paper was published with such a small follow-up, because most patients after that procedure are not walking initially like they normally would. So I'm sure that if we extended this for a year follow-up or more, that their results would be significantly significantly insignificant. How about that? Okay, so usually what's going to happen then for a lot of patients who don't get relief from all of these other treatments is that we're going to go in and cut the plantar fascia. And this seems like a great procedure, and I've even seen some license plates on a Porsche somewhere that this guy was like the heel king because he specialized in cutting people's plantar fascia. And this is just a brutal, it's just kind of a crazy procedure. Imagine if you had chronic Achilles tendonitis And we suggested to those patients that all we're going to do is go in and cut your Achilles tendon. That would be very detrimental to somebody's biomechanics. And that's the same thing that's going to happen here when we go in and cut the plantar fascia. We know of all of the different complications that can happen with it. There's been a lot of studies published on it. So let's think about this for a second. We already have a patient that their plantar fascia is being overstretched. And now we're going to cut the plantar fascia, which means that we're going to weaken the foot structure anymore. So let's think about what we're doing. We're now going to increase the strain to the spring ligament if it's even intact. We're going to then increase the strain to the posterior tibial tendon as well. So a lot of patients that come in with posterior tib insufficiency or pain, nearly a majority of them describe a previous occurrence of heel pain. So what happens for a lot of patients who undergo that year of conservative therapy and their heel pain goes away, typically they'll just auto-rupture the plantar fascia. A lot of patients will explain that they had tremendous heel pain for several days, and then afterward that heel pain subsided because the fascia just eventually gave out. And now they're going to end up with more of that posterior tib insufficiency. So that doesn't make any sense. So when we're cutting somebody's plantar fascia, are we treating the symptom or are we addressing the underlying etiology? So not only are we destabilizing the patient's foot, we're really predisposing them to even further joint pathologies and tissue pathologies. So the last thing that we want to ever do is to go in and just simply cut somebody's plantar fascia. And of course we know that the heel spur is not a contributory is not contributing to the patient's heel pain. That's just a radiographic finding. And like we talked about before, it's a form of compensation for the tissue strain. So here's a paper that was just published in Foot and Ankle Surgery in 2020. And this was they looked at the studies published on plantar fasciotomies and showed that there's weak evidence to support the treatment of endoscopic plantar fascial release. So if you want to say endoscopic or even just plantar fascial release. So here we have a paper that says that it doesn't support this. And if you're out there prescribing this to your patients and they end up with a complication, then they could potentially come back and give you trouble, because here we have this paper showing that it's not really, there's no evidence to support the effectiveness of that. So what I want to do is talk about what other ways do we have to decrease the tissue strain. So we talked about instability of the talotarsal joint. So it seems like one of the first forms of treatment that we want to prescribe to a patient is what can we do to stabilize the talus on the calcaneus that has been proven to decrease the strain on the plantar fascia by 33%. So here we can see a patient with this x-ray on the right that they have a sagittal plane deformity. The talus we have an anteriorly deviated synoline. The talus has partially dislocated anteriorly. We have a drop navicular, and we see how the calcaneus has grown that shelf of bone to try to compensate for the increased strain on the plantar fascia. Well, one of the most obvious treatments that is a biomechanically friendly treatment that is minimally invasive, a soft tissue procedure, again, that is proven to decrease the strain of the plantar fascia, is the insertion of a sinus tarsi implant. That makes perfect sense. This is like fixing the hole in your tire. I mean, yes, we still have tissue disease. The fascia is diseased. It's going to have to heal. The nerves are diseased. And the great thing with those peripheral nerves, that they are given a chance to heal if we stop the traumatic forces that are causing the tissue disease. So we have a paper that's pending publication right now showing that a lot of patients only had the insertion of the hypercure stent, and afterward their heel pain was significantly relieved. Most patients, my experience when I was using this, is within a week or two, most patients' heel pain was completely resolved. Um, yes, it could be that a patient has had heel pain for such a long time that there's so much tissue disease that you still need to go in and do a plantar fasciotomy to remove that tissue, that enlarged section of fascia that's pushing on the nerves. But that should be an end-stage procedure. For any of those patients, I would prescribe this procedure first before we did anything else. It makes total sense. Again, no matter what else you do, if you're giving them oral anti-inflammatories, heel injections, any other form of treatment, those orthotics, they still have the same underlying pathologic forces acting on their plantar fascia. So we might be able to fix them with those conservative treatments temporarily, but it's only a matter of time before it comes back. So I think that this form of treatment makes perfect sense. Again, a lot of times you're going to prescribe, you notice that the patient has that excessive hindfoot motion and that they're just walking right over their orthotics. So now we have a far superior option. So what we want to do is restore the natural mechanics to the patient's feet versus just going in and destroying those tissues. So when we're looking at the various types of treatment, we want to say, are they focused on the symptoms or are they focused on the underlying cause? So yes, if you put a patient in a fiberglass cast or put them on crutches or wheelchair, that's going to take away the forces acting on the plantar fascia and it's going to heal. But then as soon as they go back to running, jogging, whatever activity they were in the first place, it's only a matter of time before that comes back. We don't want to go in and just fuse the subtalar joint. So that's why the insertion of a sinus tarsi stent makes the perfect treatment. So you go in, put the stent in, and then we can go back, and our other forms of conservative care will be a lot more effective. Now, I recently published this book on the myth of plantar fasciitis, and it's available on the pfmyth.com. And so a lot of you already have this, and I go through and extensively, I looked at all of the literature that talks about all of the various forms of treatment. And so it's all in this book. It's all of the evidence is there. So it's really, really good. So that is pretty much the webinar that I had. And I hope that I shed a lot of light on this.